let's just in a few moments. Hello, welcome to Anatomy Physiology. This is lecture number 6, and today we will talk about one of my favorite topics is the endocrine system. Endocrine system. Another favorite are going to be the sensorial organs, like a touch, like hearing, vision, etc. All right, so let's get started without any more delays. All right. Okay, so one thing I want to mention here. All right, so there was, let me see if I have a picture. Okay. Let's talk about a little bit about the endocrine system, and just want to introduce this topic is, the laboratory tests the Egyptians, like 3,000 years ago, was actually one example. It will tell you when the person was pregnant. When you get pregnant, and what they was doing is two things. Number one is to put a thread on the suspicious woman who was pregnant over the neck, on the neck here, the neck. Very special thread with the tension and so on. Now, with running the days or the weeks, if the thread was broken, that means that that woman was pregnant. So that is the laboratory test. So they didn't have CVS or Walgreens. They was just going to the priest, and the priest was doing everything. So how is that, right? How a thread putting in your neck are going to be? This is actually it's taking several days, even weeks. So now we have the pregnancy test that is very, very fast. Another one is that they was putting in two plants, same seeds, same seed, the same plant, the same everything. And one plant was being watered with water, and the other one with a pee of the woman who suspiciously was pregnant. And if the plant actually with a pee of the woman was growing faster, that woman was pregnant. Yep. So was actually Egyptian test. And just to make it not too long, I will tell you, during the pregnancy, the endocrine system, the thyroid gland is going to be enlarged. So that's why. The thread was broken because the enlargement of the thyroid gland. And the thyroid gland always is going to get enlarged when you are pregnant. In addition to that, the pee, when women is pregnant, they are going to release some substance like estrogens. You have excess of estrogen. So women who are pregnant, they become more beautiful than ever. Do you hear that expression, right? So yeah. Women who is pregnant is more beautiful than before, than ever. Why? Because the levels of estrogens giving the texture of the skin that is very smooth. And these estrogens are being eliminated through the urine. And the estrogens are an anabolic hormone that can affect plants. The plants are going to grow faster. I will tell you one time when I find out this. My mother, I was in med school, and my mother was actually, she liked plants. Okay, and she was one time she was telling me, Guillermo, you are in the med school. Can you bring me some oral contraceptive pills? Mom, what you talking to me? What you are asking me about your sexual life? I don't want to know that. Don't tell me anything, right? And she was looking at me very innocent, right? And she said, no, it's for the plants. Why? What happened with the OCP and the plant, the oral contraceptive pill? If I put oral contraceptive pills on the plant grow very nice. Now from that I learned. So you can actually plants, they have an hormone called the phytoestrogen that is similar for the estrogens in female. Okay, all right. So doing that introduction, let's get into our topic. All right. All right, so the endocrine system is composed by several multiple of these organs, okay? So For this, I'm going to make a summary because I think it's the most convenient way in order to review on what we saw in bioscience. And I'm going to do it again for those who was not with me in bioscience. All right, so the material exactly the same. What I'm trying to add you here for the new students is a way to memorize and to recall information. For that, I'm going to go all over. All right, so number one, we have the hypothalamus. The hypothalamus. The hypothalamus is what I call, there is no in any book like that, but I call the big gossiper. Is the big gossiper. You know somebody who is gossiper? The biggest gossiper. So hypothalamus is part of the nervous system. Is part of the nervous system. Which part? The central nervous system. So that is the hypothalamus. Hypothalamus is part of the central nervous system. Now, these hypothalamus are going to contact the pituitary gland. Pituitary gland. The pituitary gland. The pituitary gland is called the hypophysis. 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 Hypophysis, or called the master gland. That is a review. So that is based on previous lecture, of course. Pituitary gland, hypophysis, or master gland. So those are the things that you need to remember very clear. Okay? All right. So this pituitary gland, what is that? Is an endocrine gland. Endocrine gland. Endocrine gland. Endocrine. Central nervous system, endocrine. This relationship between the central nervous system, hypothalamus, and the endocrine system, the pituitary gland, is going to have a mechanism of regulatory that is called the homeostasis. The homeostasis. Homeostasis. Right? Homeostasis. What is homeostasis? Homeostasis is the system that keep the internal balance of your body. What does it mean to keep the internal balance of your body? All the values that you have, your blood pressure, your respiratory rate, your temperature, your pulse, your pH of the blood, the amount of hormones that you need in certain time of the year are going to be controlled by this system. Who knows that? The hypothalamus. And who is going to I will say, implement all these orders are going to be the pituitary gland. For example, I will tell you again, and this is something that I repeat in the past. So if you need to grow, who knows that? The hypothalamus. And hypothalamus is going to send an order to the pituitary gland. Who knows that? Hypothalamus is the big gossiper. You need to grow. I need to grow. So they are going to send the orders to the pituitary gland, that is the endocrine system. And the growth hormone is going to be released. Similar, for example, you are lactating. Who knows that you need to lactate? Who knows that you need to produce milk because you are lactating a baby? Who knows that? Hypothalamus. Hypothalamus is going to send an order to the pituitary gland to produce more milk. Okay, so you are doing exercises. You are actually going to the gym. You need more energy. Who knows that you need more energy? Is going to be the hypothalamus. And the hypothalamus, what is going to do is send orders to the thyroid gland to produce more T3 and T4. And you already know very well that T3 and T4, those are hormones produced by the thyroid gland who produce more ATPs. T3, T4, ATP. So that is a function of the T3 and T4, and etc. So we have the adrenal gland. So if you are stressed, you need to release cortisol. Who knows that? Hypothalamus. You need to ovulate. When is your day of ovulation? Who knows that? Hypothalamus. Who is going to know that you have low or high levels of estrogens? Hypothalamus. Who knows when you need to pee or you are dehydrated and you need to pee less? The hypothalamus. Who knows when you are going to deliver a baby? Who knows that? Hypothalamus. In conclusion, hypothalamus knows everything. All right. So saying that, the pituitary gland are going to be divided into by the way, I need to talk about the axis. So from this hypothalamus, pituitary gland, we have that they are going to be directed to different glands. One of these glands is going to be, for example, the thyroid gland, the thyroid gland, thyroid gland, thyroid gland. Another gland will be, for example, the adrenal gland, adrenal gland, adrenal gland. Another gland will be, for example, the testicles, or could be the ovaries. All right, so now listen to this. This is a system, is like a teamwork. So all these elements need to be working properly. And we have the hypothalamus, pituitary, thyroid gland axis. I'm going to put here mammary gland too, the mammary gland. But those are examples. So you can see the hypothalamus, pituitary, thyroid gland axis. That is what we call the axis. Axis. Axis is the hypothalamic pituitary thyroid gland axis. Hypothalamic pituitary mammary gland axis. We have the hypothalamic pituitary adrenal gland axis. And we have hypothalamic pituitary testicular ovarian axis. So these are how they are going to work. For example, I will tell you the breast need to produce milk, right? When it's needed, when it's milk, need milk, right? So then the mammary gland is receiving receiving order from the pituitary gland by the prolactin. Prolactin. Okay? So, but who knows at the very beginning that you need to produce milk is the hypothalamus. The hypothalamus is going to send a message to the pituitary gland, and the pituitary gland are going to send the prolactin to the mammary gland. See, all many steps. So what happened? What happened if the mammary gland is atrophic, is not working? So actually you don't produce milk. That is one. Two, what happens if the pituitary is not working? That is not going to produce milk because the pituitary gland need to send the prolactin to the mammary gland, and if the prolactin doesn't arrive, there is no milk. So we have two levels. At the level of the target organ, at the level of the pituitary gland, and what about if the hypothalamus is not working? So if the hypothalamus is not working, they will not able to stimulate the pituitary gland to produce prolactin, and the prolactin will not go to the mammary gland. At the end, you do not produce milk. What is the point about this? The point about this is this, that if you have a problem to produce milk, the first thing to investigate is going to be the mammary gland. If the mammary gland looks okay, is not a problem, you need to look for above. Probably the pituitary gland is the problem. If the problem is not the pituitary gland, probably is the hypothalamus. Hypothalamus. Now, for example, here we have the thyroid gland. Thyroid gland produce T3 and T4. So you cannot produce T3 and T4. So that is what we mentioned before, the hypothyroidism. So you have hypothyroidism because you don't produce T3 and T4. What could be the problem? The problem will be the thyroid gland. That is the most common. The second most common, if the thyroid gland is okay, is working nicely, okay, there's no problem, they are going to look that probably the problem will be in the pituitary gland. If the pituitary gland is not a problem, will be that is less common, the hypothalamic area. Is that clear?
Yes.
Yes.
So please, I just want you to remember that these mostly of these hormones are going to follow an axis. These axes are going to follow the hypothalamic pituitary gland target organ axis. So is the hypothalamic pituitary mammary gland axis, hypothalamic pituitary testicular ovarian axis, etc. All right. So now, when there is a disease or problem, there's three levels. One level is the target organ. Could be the thyroid gland, the mammary gland, adrenal gland, testicles, ovaries. If that is not a problem, you need to go to the next level. The problem will be the pituitary gland. If the problem is not the pituitary gland, probably it's above, is higher, the hypothalamus. You okay?
Yes.
All right. So let's get started with we need the review. All right, so we have the pituitary gland, and the pituitary gland that is called the master gland, okay, are going to be divided into the adenohypophysis. Adenohypophysis. Hypophysis. Adenohypophysis. Question for the exam. Adenohypophysis is actually called the anterior pituitary gland. How to remember that? A adeno, A anterior, A and A, adenohypophysis. And the other one is the neurohypophysis. Neurohypophysis. That is the posterior. So we have anterior, obviously the other one should be posterior, right? Posterior pituitary gland. Why it's called neurohypophysis is not the scope of the class, but basically the posterior pituitary gland is an extension, is a continuation of the hypothalamus. Basically, these hormones are produced by hypothalamus and then storage in the posterior pituitary gland. But for the purpose of our class and our program, we are going to just remember neurohypophysis is the posterior pituitary gland. All right, so the adenohypophysis. In the adenohypophysis, you're going to, all these hormones that we are going to see right now are going to have, first of all, the name of the hormone name. Hormone's name, the hormone's name. Then we are going to talk about the target organ. Target organ. So where these hormones are going to work. And the last one is the function of the organ. So this is the three that you need to remember. Just one thing. What is an hormone? What is an hormone? Take your hand on the bioscience. Hormones are two classes of hormones. What is a hormone? Hormone is very simple. It's a messenger. It's actually a substance who is going to transmit a message, an order, right? So estrogens have some effect in your body. The T3 and T4 and the TSH are going to have some function in the body, right? Target organ. For example, you have estrogens. The estrogens affect many things. Well, probably it's not a good example. Estrogens are going to affect many things, but you're not producing estrogens from your nose or from your eye, right? So that means that estrogens are having target organs, the skin, the ovaries, etc. The estrogens can affect the testicles, etc. Right? So we will see that more clearly in a few moments. All right. So hormones, bioscience, as I mentioned, have two types of hormones. The hormones that are being produced by hormones that are proteins, hormones that are proteins, hormones that are proteins, and the other group of hormones are hormones that are being made by fat, especially cholesterol. And that is what we are going to see today. All right. So the majority of hormones in the body are being made by proteins. And mostly of these that we are going to see are proteins. The ones who are made by fat, that is the cholesterol, are going to be the aldosterone, cortisol, and sex hormones. So those are these three hormones are going to be produced by fat, especially cholesterol. So if you remember aldosterone, cortisol, and sex hormones, fat hormones from fat, the rest of hormones, whatever hormone I mentioned from now on, are going to be proteins. The only one are not going to be proteins, are going to be sex hormones, aldosterone, and cortisol. Is that clear?
Yeah.
All right. So now, growth hormone. Let's start. And probably this is a review. So yes, please. The first hormone we are going to talk is the growth hormone. This growth hormone is called the somatotropic hormone. Somatotropic hormone. So don't get confused with somatostatin that is produced by the pancreas. That is not. Somatotropic is not somatostatin, all right? It's different hormone. So somatostatin is produced by the pancreas. We are not talking about that right now. The growth hormone is called the somatotropic. The target organ, as you know, are the muscles and bones, right? So basically what they are doing is to promote the growth. So what is the function? Growth. Simple. Growth hormone, somatotropic. This is question for the exam. So what are the target organs? Muscles and bones. And what is the function? Growth. So just remember, 1, 2, 3. Name, target, and function. Name, target, and function. Name, target, and function. The other one is the prolactin. Prolactin. The prolactin are going to be, what is the target organ of prolactin? Is the mammary gland. Is the mammary gland. Mammary gland. And what is the function? If you can help me, please, to make it faster.
Milk.
It smells milk.
Milk
Production
what?
of milk.
Production of milk. Production. Prolactin, production of milk. All right? See, because there is another hormone that produces the ejection. So that's why I want you to memorize the prolactin produce milk. Prolactin, production of milk. Okay? Target organ, the mammary gland. Then we have the TSH. This is, look at this. These hormones are produced by the anterior pituitary gland. Anterior, the growth hormone, prolactin, the thyroid, a stimulant hormone is called the TSH. Thyroid stimulant hormone. So who produces this? Don't tell me the thyroid gland, please. Don't tell me the thyroid gland. The thyroid gland itself do not produce TSH. The one who produces the TSH, I want to make it clear, you're going to lose 3-4 points if you don't know this. The TSH is being produced by the anterior pituitary gland or adenohypophysis. Then after that, the thyroid gland, the TSH is going to stimulate the target organ, that is the thyroid gland. See? So TSH is arriving to the thyroid gland. The thyroid gland is not producing TSH. The TSH is the one who is telling thyroid gland we want more T3 and T4, right? So target organ is going to be the thyroid gland. And the function of the thyroid gland is to produce T3 and T4. T3 and T4. We okay with that? What is doing this? Is going to increase the production of ATPs. ATPs. Very simple to remember. T3, TTTTT, ATTTP. Okay, T3, ATTTP. Okay, so we have 1, we have 2, we have 3, we have 6. 4 are going to be the favorites of everybody, the ACTH. I'm going to put here the name. The adrenocorticotropin hormone. Adrenocorticotropin hormone is the ACTH. ACTH. So I'm going to make you repeat this word. Adreno, please, everybody. Adreno.
No.
Adreno.
Cortico. Tropin. Hormone.
Hormone.
Now, all together. Adrenocortico.
Adrenocorticotropin.
Exactly. You remember, right? Adrenocorticotropin hormone, adrenocorticotropin. Okay, whatever. Right? ACTH. And what is the target organ? Thank you. What is the target organ of the ACTH? Is going to be the adrenal gland. It's not enough to say adrenal gland. You need to say adrenal gland cortex. So why do you think it's called adrenocorticotropin hormone? Adreno means adrenal gland. Cortico means the cortex of the adrenal gland. If you remember, the adrenal gland is divided into cortex and medulla, right? All right. So is the cortex the one who actually produces? All right. So adrenal gland cortex. So who receives the order from? The ACTH. The ACTH. Who sent the ACTH? The adenohypophysis or anterior pituitary gland. This adrenal gland cortex can produce three things. They can produce the secretion of aldosterone. You know, what is aldosterone? What is the function of aldosterone? You should know about this now because we are going to use that as a base. So aldosterone are going to reabsorb sodium, reabsorb sodium, reabsorb sodium, reabsorb sodium, and is being followed by water, aldosterone. So basically, it's a regulator of the blood pressure. So we have the cortisol that you must remember the table of 10, and I'm going to go over the table of 10 again, right, to make it fair for everybody. Cortisol, they have 10 functions. If you remember, we can do it now. Cortisol is the stress hormone, number one. Number two is make you awake. Number three is increase the glucose in blood through that gluconeogenesis. Number four is going to depress the immune system. Number five is going to be osteoporosis. Number six, okay, so help me. It's going to be anti-inflammatory. Number seven is going to produce gastric acid, going to produce irritation or produce gastritis. Number eight is going to be retention of water, sodium retention. Number nine is going to be lipolysis. That means that is going to release what? Release fats, fatty acids from the triglyceride. And number 10, what is number 10?
Osteoporosis?
I said osteoporosis or no?
I'm not sure.
We are going to make a list again. All right. So that is the functions of the cortisol. Who produces that? The adrenal gland cortex. Who is going to stimulate by? The ACTH. Who produces the ACTH? The anterior pituitary gland. So, and the other one are the sex hormones. Sex hormones, what are those? Estrogen, progesterone, testosterone. Okay. Number 5, we have the LH, the lutein hormone, or luteiniscent hormone, is the same. Hormone is going to be the LH. What is the target organ? Ovary. And the ovary, what is going to do? Everybody?
Produce ovulation. So
Ovulation, very good. The ovulation. Ovary produce the ovulation, lutein hormone. But now LH can stimulate who else? The testicles. The testicles. Male, we don't produce ovulation. But what is doing the LH on the testicles? The LH on the testicles, what they are going to produce is the testosterone. Testosterone. Now, testosterone, okay? Then we have the number 6 is the follicular stimulant hormone, is the FSH. The FSH are going to have a target organ, the ovary. And the ovary, what is going to do is to increase the production of estrogens. And in the testicle, the FSH, what they're going to stimulate are going to be the Sertoli cells. What are the Sertoli cells? Just to refresh you, Sertoli, those are what we call the nursing cells, the sustentacular cells that you saw in bioscience. Sertoli cells, sustentacular cells, or nursing cells. Who are doing that? Are taking care of the spermatozoids. Okay? So there you are. So there we have 6 of these hormones of the anterior pituitary gland that are going to have a target organ, each of them, and they are going to have a function. Okay? You got it?
yes.
Okay. Now let's keep moving. Now that we talk about the pituitary gland and we talk about the adenohypophysis, okay, or anterior pituitary gland, it's time to talk about the posterior pituitary gland. The posterior pituitary gland, or called the neurohypophysis. Neurohypophysis. These neurohypophysis, posterior pituitary gland, are going to have how many glands? Two glands, two hormones. One is the what? The oxytocin. Thank you. Oxytocin, and the oxytocin is produced by the posterior pituitary gland or neurohypophysis. Are going to have two target organs. One target organ. This is the name of the hormone. This is the target, and the target is going to be the mammary tissue. Mammary tissue. The mammary tissue. Breast. And this, what is doing the function of this? The function will
Ejection.
be ejection. Listen to this. Very good. Ejection of the milk. Ejection of milk. Ejection of milk. Of muscle milk. The ejection of milk. That is the difference between the oxytocin and the prolactin. Prolactin production. Oxytocin ejection of the milk. Then we have the other one is the uterus. The uterus. The uterus, what is doing is the labor. Is going to be the contraction of the uterus. That is the oxytocin. And the other one is the ADH. ADH. Who is the ADH? Is the antidiuretic hormone. Diuretic hormone. This antidiuretic hormone, what is doing is to reabsorb water. Reabsorb water at the level of the distal convolute tubule. Distal convolute tubule. And this reabsorption of water, the reabsorption of water is without the participation of sodium. The one who participate sodium in the absorption of water is the aldosterone. The ADH do not absorb sodium. They absorb directly water. You okay with that?
Yes.
Okay. So saying that, that is the review of what we was talking in previous class. Okay. So this is a review. So I went over again. I should mention it, but I did over again. All right. I did it again. All right. So here we have hormones are going to be two types. Hormones can be proteins based on amino acids, proteins, and the other one are going to be lipids. So I'm repeating, yes. As you can tell, I repeat everything 3 times. So that's why I want you to be sure that you got information. All right, so all hormones are going to be basically proteins. Few hormones, like for example, the aldosterone, the cortisol, and the sex hormones are going to be called steroids. So why are going to be called steroids? So let's make a shortcut here. Look at this. Please be careful with this. Steroids are who? Are the aldosterone. Is the aldosterone is the cortisol, and is the sex hormones. Are the sex hormones. Sex hormones. Sex hormones, we have the estrogen, we have the progesterone, and we have the testosterone. So all of these are steroids. All of these. So please, you are in different level now. If you go to the news, or somebody was using steroids because high performance in physical activity. So and they said testosterone. Testosterone, yes, is an steroid, but it's not the only steroid. It's not the only steroid. Obviously, the steroids is estrogens, right? Nobody's going to put estrogens to have high performance, right? So everybody understood that it's testosterone. But a steroid is not only estrogen, it's not only progesterone, it's not only testosterone, it's cortisol, it's an steroid, a steroid, a steroid. Nail it in your mind. Cortisol is an steroid. Aldosterone is an steroid. Aldosterone is an steroid. And this steroid, where is coming from? All these steroids, aldosterone, cortisol, sex hormone, are going to come from, I'm going to write it down, from the cholesterol. Can you see? Cholesterol, esterol, estero. That's why it's called steroids. We okay with that? All these, you need cholesterol. For what? To produce aldosterone. Yes, you need cholesterol to produce cortisol. Yes, you need cholesterol to produce estrogen, progesterone, and testosterone. We okay with that? And these are cholesterol. What is cholesterol? Fat. What is the classification of fat that you know very well? Fat is the same to say lipids. Lipids and fat, you can say, no, be afraid to say is the same, are going to be the fatty acids, the triglycerides, and the cholesterol. So that is the classification of fat. Okay? And cholesterol is fat. Yes, fat cholesterol. These hormones are coming from fat. Which fat? Cholesterol. Cholesterol is fat? Yes. What is fat? Example, cholesterol. Cholesterol is fat? Yes. Fat. Cholesterol, fat. Triglycerides is fat? Yes, it's fat. Fatty acids is fat? Yes, it's fat. You can say fatty acid is a lipid? Yes, it's a lipid. You can say triglycerides is a lipid? Yes, it's a lipid. Cholesterol is a lipid? Yes, it's a lipid. Don't be afraid of the terms. Now you know. All right. So the lipids are going to be most of the lipids, hormones like aldosterone, cortisol, and sex hormones are going to be called steroids. All right, so let's talk about the negative feedback. All right, so I'm going to mention one thing only that is going to help us to understand that. Do you know that we have the LH and FSH? Okay. So in order to ovulate, you need to have FSH and LH. Ovulation itself is by the LH, but the process of ovulation starts with the increase of estrogens that is being given by the FSH. Okay, so now, do you know that women who are who have a baby and lactate, they're going to have some successful to not get pregnant for the next 6 months? Do you know that?
Mm-hmm.
Right? So basically, in other countries, poor countries, they are actually having the lactation as one of the main ways to control pregnancies, right? It's only 15% secure, 15, but it's better than nothing, right? So that's why when you are lactating, you do not ovulate. So if you are lactating, you are not ovulating at least for the next 6 months, right? So you are not ovulating. So if you are not ovulating, you are not going to produce, you are not going to get pregnant, right? So now, for the ovulation, you need to increase the levels of LH, and before that, the FSH. So during your menstrual cycle, your FSH go up and your LH go up in different moments, right? But they need to go up. But when you are lactating, who knows that you need to produce more milk? The hypothalamus. And the hypothalamus is telling the pituitary gland to produce more prolactin, anterior pituitary gland, and the prolactin is going to produce more milk. Why? Because you are lactating, right? That production of prolactin, when it's increased, are going to stop the production of LH and FSH. So that is a typical case of negative feedback. Negative feedback. Negative feedback. Let's go to the midterm to Wednesday, and you overspeed 80 miles per hour, but the sign is telling you 65. So that means that you are too fast. So you need to decrease your speed. Now, if you have 25 miles per hour and the speed is 65, you are too slow. The sign is telling you to accelerate. So that is what happened. So when you have excess of some hormone, that is going to basically tell the brain that do not produce anymore this substance. And that's what happened with the prolactin and the FSH and the LH. So please, I want you to get this. FSH, LH are going to be called the gonadotropic hormones. Write it down. Write it down. Gonadotropic. What means gonad? What is gonad?
The sex.
Ovo and
Ovo, yeah, it's spermatozoid.
The sex
Gonad.
organs.
Please. Gonad is reproductive organ. Gonad is going to use a lot, okay? Gonad. Gonad, what is a gonad? Testicle. What is gonad? Ovary. What is ovary? I mean, what is ovary? A gonad. What is the testicle? A gonad. Okay? So you can call gonadal arteries. Gonadal arteries is the arteries who give blood supply to the testicle and the ovary. Gonadal artery on the testicle is called the testicular artery, but it's a gonadal artery. So you need to know that gonad means reproductive organ. Okay? All right. And the FSH and the LH are essential to produce the ovulation. All right? So the cycle at the beginning, FSH, and then day 12, the FSH is going up. Day 14, the ovulation occurs. So you need that. But when you are lactating, the prolactin is going to be as a negative feedback to the FSH and LH. So in conclusion, what is doing the prolactin? The prolactin says, when this increase, FSH and LH don't appear. I don't want you to come. Stop. There is no FSH, LH on my side. So when I have prolactin, they don't like to see FSH and LH. All right? So prolactin increase and the FSH, LH decrease. So that is a negative feedback. Negative feedback. Is that clear?
Yes.
A positive feedback will be, for example, when you are when you have low levels of estrogens. When do you have the lowest level of estrogen, girls? Are the day of the menstrual period, the bleeding days, right? It can be 1, 2, 3, 4, 5, even 7 days, right? Average 3 to 4 days, average. Now, that is the moment that you have your lowest level of estrogens. Who knows that? The hypothalamus. The hypothalamus says, wait a minute, we have a little bit of estrogen. We want more estrogen. Come on. All right. So what is doing the hypothalamus? He's saying, okay, pituitary gland, you know what? Wake up. We need to produce estrogens. So that means the lowest level of estrogens are going to stimulate the pituitary gland to produce the LH and FSH. That is a positive feedback. You are too slow in the highway. You have 25 miles per hour and say, you know what? You have 65. What are you talking? So, okay, let's accelerate. So that is what is a positive versus a negative feedback. You okay with that?
yes.
Okay. All right, so let's keep going. So here we have the third repetition of fourth. So we have pituitary gland called the hypophysis or master gland. So please, if I ask you, what is the hypothalamus? Endocrine or endocrine or nervous tissue? Hypothalamus,
Nervous.
nervous tissue. You just remember, hypothalamus is part of the diencephalon. Those diencephalon, that is in the center of the what? Of the brain. Hypothalamus, just to give you an idea, so when you are dissecting, when is somebody somewhere you dissect, the hypothalamus is the size of a grape, of a grape, of a grape. Yeah, that is about the size of a grape. And the pituitary gland that is below of the hypothalamus is the size of a pea. Not P, how you pronounce P versus P? P-E-A, right? So that is the size of the pituitary gland versus the hypothalamus. Okay, so hypophysis, master gland, gland located in the base of the brain that produce number of hormones. So yeah, we can read that. Division, anterior pituitary gland or adenohypophysis. One more time. A anterior, A adenohypophysis, A anterior pituitary gland is the same. Posterior pituitary gland is called the neurohypophysis. That is something that you need to remember. All right, so hypothalamus. So we already talked about that. Hypothalamus is gray matter, are the sinkers, right? Okay. All right, so here we have the growth hormone for the third time. I'm repeating, the growth hormone or somatotropic hormone. What is the target organ? Muscles and bones. And what is the function? Is the growth. Thyroid stimulant hormone, the TSH, is actually the TSH is going to be produced by the pituitary gland, anterior pituitary gland, correct? So the TSH, what is the target organ? The target organ is the thyroid gland. What is the function? Produce T3 and T4. The ACTH, the adrenocorticotropin hormone, or adrenocorticotropic hormone, the ACTH. ACTH is going to be the adrenal gland cortex, right? Tropic hormone. So adrenal gland cortex, not the medulla. The medulla, what is the medulla? The medulla is not part of this. The medulla is going to produce neurotransmitters, the adrenaline and the noradrenaline, epinephrine, norepinephrine. And that is connected. It's like you have a wire connected to the wall. Your device is the adrenal gland medulla, and the wire on the wall is the sympathetic nervous system. So they go directly to the spinal nerves. So coming directly from the spinal nerve. That is the medulla. Nothing to do with this axis that we are talking, the hypothalamic, pituitary, adrenal gland axis. No, the adrenal gland axis, again, is going to work only for the cortex, not for the medulla. Okay? Prolactin, again, target organ, the breast function, production of milk. Gonadotropins or gonadotropic hormones, for the third time, I'm repeating this. So LH and FSH are called gonadotropic hormones. Okay, we have another one, the GnRH. We have the human chorionic gonadotropin hormone. Another time when we are doing the last class of anatomy. Then we have FSH and LH. FSH, what is doing? Increase the estrogens. FSH, target organ, the ovary. And what is doing the ovary? Is going to produce more estrogens. That is the FSH. In testicle, the FSH stimulate the Sertoli cell. Sertoli cells and the production of spermatozoids. I forget that. And the formation of spermatozoids. Sertoli cells and formation of spermatozoids. FSH. More spermatozoids. Yes. Do males, do we have FSH and LH? Yes, we have FSH and LH. We have LH? Yes. LH, what is doing in women? The ovulation. What is doing the LH in male? Are going to be the production of testosterone. Okay? And the hormones of the posterior pituitary gland are going to be the ADH, the antidiuretic hormone. For this, you need to remember very well what is diuresis. Diuresis means production of pee. You pee. So tell me one thing that you drink and you eat or drink that produce pee. That is going to be, for example, alcohol. When you have alcohol, you don't pee more often. Yes or no? Right?
Yes.
Right? So when you that is diuresis. So, but this is called the anti-diuresis, anti-diuretic hormone. That is the ADH. So it's doing the opposite. So it's not going to allow to produce too much urine. Why is that? Because most likely you can be dehydrated. So you don't want to lose. You want to preserve as much water you can. So that's why you urinate less. Okay? All right. All right, so we are going to go bit by bit from this. And that is the moment we are going to start elaborating. That what I just talked was the introduction. All right, so it's time for a break. Chia, tell me, it's time for a break?
Yes.
Okay, 11:40. So you want lunch break? I think let's go lunch break. And what you know what I'm doing because I'm trying to skip the 10 minutes break because I know we are short in time, right? You do that, right? Okay, very good. So let's do the lunch break. I will see you 12:10.
Okay.
Any question?
No, thank you.
No.
This is a review, huh? So the new things are coming. So please, on time. Okay, see you then. If somebody's in camera, probably you need to ask me question. All right, I'm going to pass the grades. Okay, so I'm going to cut my presentation and I'm going to show the grade, to pass. Okay, all grades are there. So I'm coming back at 12:10. If there is any question, let me know, please.
How you doing, Anna? ¿Cómo está? Mabote? Magando Magapo?
Mabuti. Very well said.
Yeah,
Your ex-wife taught you really good.
yeah. Well, yeah. I just know a little only. Conti long.
Konti lang.
Yeah.
How long have you been deployed, actually?
I was over there 4 years
Wow.
in Philippines. Yeah.
Yeah.
Now, wait a minute. I got questions about the. He said the exam is the afternoon homework is going to be 100 questions, and it's going to be based on everything that's going to cover up to the midterm review.
I think.
Okay.
Are you talking about anatomy and physiology?
Yeah, anatomy and physiology today
Yeah.
at 3:00.
Until starting from 1 to 5, I guess.
Okay, I'm trying to figure out why is it going to be 100
Yeah.
questions because I know it's not.
You
Yeah,
know what?
you should
Mr.
ask Dr.
Continue,
about
continue.
that.
Why is
I
going to
think
be 100 questions? What do you
Yeah.
think? Okay, explain me. What is your question, please, Otis?
Oh, okay. This 100 questions is going to cover from chapter 1 all the way up to lecture 1 all the way up to lecture now, right?
No,
Lecture.
these 100 questions are actually only endocrine.
Wow.
Oh.
I can
Okay.
reduce that to 50.
Is there a midterm review, a set of questions exam?
No. All right, so please, everybody pay attention, okay? The reviews for the midterm exam is going to be from lecture 1 up to this lecture. Okay? Now, how is going to be prorate the exam? Basically, I'm trying to do is more questions from the last lecture because this is minimum need to be about 25 questions. So about 20, 25. So it's variable. So don't tell me that I put 26 or 25. No. All right. So the majority of questions are going to be from that last lecture. So from this lecture, the majority. But and other questions are coming from lecture 1, 2, 3, 4, and 5. Is that clear?
Yeah.
Okay. So now the exam is going to be 50 questions, the midterm. Okay. The review for endocrine is huge. So that's why I found a good question for endocrine. But definitely, I think I'm going to stick with 50 questions because I want you to focus on all the course, not only endocrine. So you are, as a student, you need to know everything from lecture 1 to lecture 6. Okay with that? Okay, I'm going to see how many questions I'm going to put in the review for endocrine. So actually, you will have time to review, study everything. You should be already know all the material. Review is an extra, right? And the tutoring, I'm going to have a tutoring tonight and tomorrow because of the midterm. In the final exam, I will do the same. Okay? Any question, Mr. Otis?
No, none.
All right, excellent. Well, I have some visitor here before, so good luck.
Right on. Check him out.
This is Vanusha.
What's her name?
Vanusha.
Anusha.
Vanusha.
He's a lucky cat, the one with money that goes like this, hello at the door, right? The money cat. It's like,
Yeah.
good luck.
I call him a little wombat. He look like a wombat. You know wombat, right? Okay. Wombat is an Australian marsupial. Okay. You want anatomy, right? Okay. All right, so let's get started. Okay, Vanessa, you pay attention, okay? Okay. All right, so let's get started here. All right, so I want just to let you know about, remember, what is the mnemonic to remember all the hormones of the anterior pituitary gland?
GP tau F.
GPTLF, right? So for GPTLF is the mnemonic that I use to remember all the adeno hypophysis of anterior pituitary gland. GPTLF. GPTLF. Growth hormone, prolactin, TSH, ACTH, LH, and FSH. All these hormones are produced by the pituitary gland, the anterior pituitary gland or adenohypophysis. We okay with that? So don't tell me that TSH is produced by the thyroid gland. The TSH is produced by the anterior or adenohypophysis. Is that clear?
Yes.
Okay, perfect. Okay. So here we are going to start talking about the thyroid gland. All right, so, but first of all, here we have the growth hormone. The growth hormone are going to, sorry, oh, yeah, the screen. Oh, God. Okay, for those students who didn't have bioscience with me, just remember this mnemonic, GPTAL F, GPTAL F, okay? Growth hormone, prolactin, TSH, ACTH, LH, and the FSH. Okay with that? Everybody got it?
Yes.
All right, so let's start with the growth hormone. The growth hormone, and this is partially review, we have actually, when you have an excess of the growth hormone, they are going to produce gigantism and acromegaly. Gigantism is basically happening in children, right? In children. So childhood are going to produce gigantism, and acromegaly is going to be in adults. In adults. All right. So now, what is the difference between them? Gigantism, you have, if you remember the epiphyseal plate of the bone, when we call the growth cartilage. These growth cartilage are not totally few, or complete the function. So mostly of the gigantism that happen is you have an enlargement in the length of the bones, on the length of the bones. The length of the bones are going to be mostly affected in gigantism. In acromegaly in adults, where the bones are already fused and all the growth cartilage is gone, basically what you're going to grow are the short bones. For example, we have a very prominent mandible or jaw, right? So that, or distal portion of the hands, that is acromegaly. All right, so that is about. Now, the thyroid gland. So please, the thyroid gland is one of the most vascularized glands, is the most vascularized glands in the body. You know what is vascularization, right? If you don't know, tell me now. All right. So I mentioned that in the previous class, like remember the vascularization and the innervation, those two words that I want you to remember, right? Okay. Vascularization means a lot of vessels arriving to the thyroid gland. So these thyroid glands are located anteriorly to the neck, but below the thyroid cartilage. What is the thyroid cartilage? Is the Adam's apple. All right, so below that we have the thyroid gland. These thyroid glands are going to have many functions. The two main functions that we are going to start talking is the production of the T3 and T4. T4 is called the thyroxine. Question for the exam. Thyroxine. Okay? What is doing the T3 and T4? For the fourth time, I'm telling you, produce ATPs. The more T3 and T4 produce more ATPs. So when you are doing exercises, you increase your metabolism, your body needs more ATPs. So who knows that? Hypothalamus. Hypothalamus is sending the pituitary gland a message that says, okay, we need more T3 and T4. So the pituitary gland is going to send the orders to the thyroid gland through the TSH. So who produces the TSH? The anterior pituitary gland. The TSH are going to arrive to the thyroid gland, and the thyroid gland are going to produce T3 and T4. Now, look at this. The T3 and T4, they need ingredients in order to make, in order to the thyroid gland be able to produce T3 and T4. So what is doing the thyroid gland? The thyroid gland is going to collect iodine. Is going to collect iodine. Where is coming the iodine? The iodine is coming from your diet, from the diet. Diet is going to provide iodine. This iodine, they go then to the thyroid gland, and the thyroid gland are going to produce the T3 and T4. The T3 and the thyroxine. You okay with that? All right.
Yes.
So when you don't have enough iodine, when your iodine is low, and you in your diet you don't eat iodine, the thyroid gland starts to get enlarged. It's going to get enlarged. Why the thyroid gland get enlarged? Because that is trying to get bigger in order to try to collect the few iodines that are still in blood. So that is called goiter. Goiter. What is goiter? An enlargement of the thyroid gland. The most common cause is the deficiency of iodine. You okay with that?
Yes.
Okay. So here, repeat again. Thyroxine is T4. T3 is a triiodothyronine. I'm going to ask about thyroxine. Why is called triiodothyronine T3? And the other name of thyroxine is the tetra iodothyronine. So tetra means 4. Triiodo means 3. So this T3, they have 3 molecules of iodine. And T4, they have 4 molecules of iodine. That is what is composed. That's why I'm telling you, the thyroid gland, in order to produce T3 and T4, they need iodine. Okay? All right, so that is one. Second, we have the calcitonin. So calcitonin is going to, you remember what are the values of calcium? The values of calcium is 8.5 to 10 milligrams per deciliter. So that is the levels of calcium in blood. Why do we need calcium? We need calcium for many reasons. You need calcium for muscle contraction. Which muscle contraction? The cardiac muscle contraction, the smooth muscle contraction, the striate muscular, skeletal, or voluntary muscle. All these muscles, they need calcium. In addition to that, calcium are going to be needed in order to produce the electrical impulse in the nerves. So calcium is needed for many reasons. Another reason that we need calcium is to produce bone. So they are going to produce or deposit in the bone. Remember, people who are doing more exercises, they have stronger bones. Exercise are going to promote the deposit of calcium in the bones. So we have calcium, we have in the nervous system, in the muscular system, muscular tissue, nervous tissue, and the bone tissue. So that is the functions of the calcium. So calcium, they need to be regulated. And that's what we call the homeostasis of calcium. Homeostasis of calcium means keep the internal balance of calcium. What is the internal balance? Is 8.5 to 10. If you have less than that or you have more than that, actually your nervous system is not going to work properly. Your muscular system is not going to work properly. You're going to have weak bones. All right, what is this regulation? So for this, you need to remember that we have another hormone that is the PTH. PTH. The PTH is the parathyroid hormone. Parathyroid hormone is produced by the parathyroid gland. It's going to produce by the parathyroid gland. Parathyroid gland are going to be a number of 4. So those are like small areas measured 2 millimeters behind the thyroid gland. That's why it's called parathyroid gland. Para because it's parallel to the thyroid gland. Okay? So, but the parathyroid gland is not the thyroid gland. The thyroid gland is one gland and the parathyroid gland is a different gland. So what are the functions of these guys? Okay, let me see. Manusha, let me make space. Yeah, Manusha. Okay, so we have here the hypothalamus. Here we have the thyroid gland, the pituitary gland, pituitary gland. We have the thyroid gland. Thyroid gland. And the pituitary gland is going to send the TSH. So what they're going to do is increase the levels of T3 and increase the levels of T4. So that is what we call the hypothalamic pituitary axis, the HPA, the hypothalamic pituitary axis. So hypothalamic pituitary thyroid gland axis. So that is one function of the thyroid gland. The thyroid gland, in addition, are going to produce the calcitonin. Calcitonin. Who produces that? Is the thyroid gland. Thyroid gland. And who tell the thyroid gland to produce calcitonin? Are going to be the excess of calcium. Excess of calcium. So that means that here to produce calcitonin that is produced by the thyroid gland as well. The thyroid gland produces calcitonin. So we have 3 hormones, T3, T4, and calcitonin. The difference is that T3 and T4 are going to follow the HPA, the hypothalamic pituitary axis, hypothalamic pituitary thyroid axis. But the calcitonin that is produced by the thyroid gland is going to be produced by the thyroid gland, but the stimulus to produce this calcitonin by the thyroid gland is the excess of calcium. Excess of calcium. If you have more than 10.5, means 11, 12, 13, actually that is an excess. So what is doing the calcitonin? The calcitonin, what is going to do is to activate the osteoblast. And the osteoblasts are going to deposit calcium in the bones. So another way to say this. So calcitonin, tell me if this is true or false. Calcitonin decrease the levels of calcium in blood, yes or no?
Yes.
Yes, right? Because the calcitonin is going to take that excess of calcium that is in the blood and put it into the bones through the osteoblasts. So now your normal values of calcium will be between 8.5 to 10. 8.5 to 10. Sorry, 8.5 to 10. When it's more than 10, well, let's put it more, 11, 12, that is when the calcitonin is going to be released. Be okay with that? In another side, we have the parathyroid gland. Parathyroid gland. The parathyroid gland are going to be located posterior to the thyroid gland. This is the thyroid gland, and I'm going to draw the parathyroid glands here in dots. because I'm trying to show you that is posterior and posterior to the thyroid gland. So this is one parathyroid gland, another parathyroid gland, another parathyroid gland, another parathyroid gland. We have between 4 to 8 of these parathyroid glands. Okay? We okay with that? Now, when you have a parathyroid gland is going to release the parathyroid hormone. The parathyroid hormone. What is doing the parathyroid hormone? The parathyroid hormone are going to activate the osteoclast. So in the exam, they can come like this: osteoclastic activity. So that is you understand that this osteoclastic activity means the activity of the osteoclast. And what is doing the osteoclast? The osteoclast is going to remove calcium from the bones and put it back into the blood.
Well,
So this parathyroid gland, who stimulate the parathyroid gland, is not the HPA. It's not the HPA. The parathyroid gland is going to stimulate by low levels of calcium, low calcium levels in blood, of course, in blood, all right? And that is the trigger for the parathyroid gland to produce the parathyroid hormone that activate the osteoclast and remove calcium from the bones and put it back into the blood. So in this case, for example, let's put it this: we have 6 milligrams per deciliter. When the normal values of the calcium, normal values is 8.2 to 10, right? So when it's too low, in the blood, your muscles are not going to work. Your nervous system is not going to work properly. You are actually have problems with all these systems. So what they're going to do is the homeostasis. So when it's too high, the calcium in blood, they're going to produce the calcitonin. When the calcium is too low in blood, they are going to produce the calcitonin. You okay with that?
yes.
All right. When you have high levels, I will put here. When you have high levels of calcium, what happens? This is another question for exam. When you have hypercalcemia, and you already know what is hypercalcemia. Hyper high is calcium in blood, and you have more than 10, so 11 or 12, whatever, that hypercalcemia is going to produce flaccid muscles. Flaccid muscles means that are going to be relaxed, totally relaxed. You cannot contract your muscle. That is hypercalcemia. In hypocalcemia, when it's less than 8.5, the levels of calcium in blood, you have spastic muscles. So that means contraction of the muscle. Contraction. You okay with that?
Yeah.
Okay, perfect. All right. So everybody has a chance to tell me. If you don't tell anything, I cannot guess. All right. So here we have, again, we are going to talk about some diseases. We have goiters, that is basically by the low levels of iodine in blood. So you don't need iodine, whatever it is, right? So this goiter, this is what we call goiter. Look at this goiter. This goiter are going to be the enlargement of the thyroid gland because of the deficiency of iodine. Okay? All right. So just to make it simple, because I can include, for example, if you don't have enough iodine, you cannot produce T3 and T4. You do not produce T3. You cannot produce T3 and T4. But who knows this? Who knows that is the hypothalamus. Hypothalamus is telling the pituitary gland, okay, pituitary gland, you know what? We need more T3 and T4. And that pituitary gland, what it's doing is to send a lot of TSH, high TSH, a lot of TSH. They are yelling to the thyroid gland to produce more T3 and T4. So there is a lot of TSH because it's low levels of T3 and T4. But the poor thyroid gland cannot produce T3 and T4 because they don't have iodine, for example. They don't have iodine. So that's why the stimulus of enlargement of the thyroid gland is caused by the increase of the TSH. The TSH is yelling to the thyroid gland to produce T3 and T4, but they don't have the ingredients to produce the T3 and T4. Okay? All right. So when you have low levels of T3 and T4, that is called the hypothyroidism. Hypothyroidism. Hypothyroidism means low T3, low T4. Okay? And this hypothyroidism is very important to know a few things. Number one, is very common to see in the United States. You will see in pharmacology that the Hashimoto hypothyroidism, that is an autoimmune disorder, are going to be the most common cause of hypothyroidism in the United States. In other countries, the most common hypothyroidism cause is the deficiency of iodine. Hypothyroidism are going to be low levels of T3 and T4. Now, that means what? That you have low ATPs, low number of it. You cannot produce ATPs because what is doing the T3 and T4? T3 and T4 go to the cell and make the cell produce more ATPs. But if you don't have too much this T3 and T4, you don't have the energy to do the activities of the cell. And that is going to affect, especially when the mother is not having a good diet with iodine, the fetus inside the uterus are going to suffer. How is that happening? Because the mother do not make pass the T3 and T4 to the baby. No, the baby are going to have his own thyroid gland. At 10 weeks of gestation is where the baby start to produce his own T3 and T4. So basically, the baby is on her own, in order to produce T3 and T4. But the mother do not provide enough iodine, malnourished, for whatever reasons. The mother is not giving iodine in his diet. The iodine pass the placenta barrier, but not the T3 and T4. So now, in the fetal stage, the baby is going to have a huge demand of energy. Why? Because the baby is developing. The baby is growing. So for that, you need to have, there's mitosis everywhere. And for that, you need energy. And the baby doesn't have that energy because the mother doesn't have iodine, actually doesn't provide the nutrients, iodine, to make the baby produce his own T3 and T4. So what happened? The first system that is going to be damaged or affect is the nervous system. So the fetus literally is going to born already with mental retardation because the number of nerve cells that the nerve cells reproduce in early stage, right, are not reproducing because for that you need energy and you don't have the energy. The baby is not able to produce the T3 and T4. This is called the cretinism. That is a picture of cretinism, and basically there is a delay on the psychological, physical, motor activity of the baby. So the baby is going to be very late to talk, very late to grow, very late to actually do the stages of the baby when he's developing, right? So that is what happened. Okay, we okay with that? Mixedema, very simple, is accumulation of fat. Fat accumulation is accumulation of fat. The mixedema in the hypothyroidism are going to be happen on the tibia, on your leg. It's called the tibial or tibia myxedema. Myxedema. Hypothyroidism can happen not only in fetus, but in adults too, of course, right? And you see that there is a myxedema. Myxedema is it's called pretibial, just to make it more precise. More pretibial myxedema. Pretibial is deposit of fat in the tibia anterior to your leg, right? So that is characteristic. That is in hypothyroidism, myxedema. But myxedema can happen too in hyperthyroidism. And we are going to see in a few moments. Now, in hypothyroidism, how you recognize a patient with hypothyroidism. Oh, okay. The hypothyroidism are going to just be, I'm going to start very simple. I'm not going to go all the signs and symptoms, okay? But very simple. Vital signs. Your vital signs. What are your vital signs? Your vital signs are the respiratory rate. It's going to be your heart rate. It's going to be your blood pressure. It's going to be your temperature. And all these, if you know 1, 2, 3, 4 vital signs, in hypo means low, all these vital signs are going to be diminished. So you have low respiratory rate, you have low heart rate, you have low blood pressure, you have low temperature. So if you have low temperature, this patient is going to suffer from actually chills all the time. He's cold all the time. He's cold, or this patient is cold all the time. It's cold all the time. Okay? It's cold all the time. So that means if the patient is cold all the time, right? Everybody is in t-shirts. Everybody just light clothes because his temperature is okay or high, but this patient is still having sweaters or whatever in order to protect against the cold. So just remember, very simple, hypothyroidism, all the vital signs. There is other signs and symptoms that we can discuss when this med search or when this pharmacology. Okay, but if you want to discuss that, I'm on it. Okay, now let's go to hyperthyroidism. Do you see these people walking on the street? Some of them. What is the characteristic of this patient? This patient, you see, if you see each other, and that's what we saw in previous, is the eyelid of your. This is the eyelid of your eye. These are your eyelashes. They're straight, whatever, right? And the eye is like this. That is normal. So that means that the iris, the color of your iris, the color of your eyes, are going to be partially covered by the upper lid, right? But here, look at this. Oh, you see the whole iris. You see the whole white area, all the sclera. So that is telling you that the patient can have hyperthyroidism. Please be careful with this. In medicine, one sign or symptom, one sign do not make diagnosis. You need to do the whole process in order to confirm. It's just an indicator, but it's not actually giving the diagnosis. It's called pathognomonic another time. All right? So if these patients are going to be very irritable. If you see somebody like that, be careful, because these patients, sometimes they have similar signs and symptoms of schizophrenia. Yes, schizophrenia. Schizo means division, phrenia, personality. So they have two different personalities. And actually, they are very irritable. So schizophrenic. So please pay attention to me. I'm not saying that this is schizophrenic. It's not. They have signs and symptoms of schizophrenia, but it's not schizophrenic. You okay with that? For example, if you go to the hospital, a psychiatric patient, always when they have a patient, always they want to check the T3 and T4. If they are high, they're hyperthyroidism, because in the past, there was many patients hospitalized and tagged as schizophrenics when they were not schizophrenic. Is that clear? So please don't tell me that hyperthyroidism are schizophrenics. They are not. They are having episodes when they have actually high levels of T3, they have signs and symptoms of schizophrenia behavior. And why I mentioned that so much, because these patients, when they have a crisis of hyperthyroidism, they can commit suicide. They are actually having suicidal thoughts. So we need to be careful with that. In hyperthyroidism, the disease is called the Graves' disease. Graves' disease. And why we have these bulging areas, bulging eyes? Why? Because, as I mentioned in the previous slide, in hyperthyroidism, you have what we call myxedema too. The myxedema. What is myxedema? The concept is you to know myxedema is the deposit of fat. Where is this deposit of fat? This deposit of fat in hyperthyroidism will be behind the eyes. So there is so much deposit getting behind the eyes that fat is going to push forward the eyes. And that is what is making you have this appearance. You okay with that?
Yes.
Okay. All right. So we have different terminology here, but I want just to go to the signs and symptoms. There is many signs and symptoms, but what I want you to remember is easy way is the vital signs again. You have high respiratory rate, opposite of the previous one. High heart rate, high blood pressure, high temperature. So you're hot. Everybody's using the opposite. Everybody's using jackets, coats, whatever, and you are in t-shirt. All right, so because you have this hyperthyroidism. You okay with that?
Yes.
Thyrotoxicosis is a term when you have elevation of T3 and T4 more than the unusual elevation of T3 and T4 in a patient with hyperthyroidism. In hyperthyroidism, it's very difficult, the treatment. You need to educate the patient very much. And that we will talk about pharmacology and med-search. For example, T3 and T4 are produced according to the needs of the energy that you have. So that's why you need to have a steady life. You have a routine life that you need to do basically the same physical activity every day because you are taking medication. So if you do less physical activity, you need less T3 and T4. So you are taking your medication, you need to decrease the medication. If you are doing more physical activity, you need to increase your T3 and T4 in cases of hypothyroidism, right? So sometimes when you have not a steady life, they are going to have, the needs are going to be too high or too low. They can lead into hyperthyroidism. So a patient who have thyroid problems sometimes will be hypo and sometimes can be hyperthyroidism, right? So depends on the physical activity and the dose you are taking up, okay? Thyrotoxicosis means this elevation of T3 and T4 with companion with signs and symptoms of hyperthyroidism. Tremors, irritability, hyperactivity, etc. So those are hyperthyroidism. Thyroid storm. Thyroid storm is when you have very high levels of T3 and T4. It's like a storm of T3 and T4. That is the moment when the patient can get into this irritability, schizophrenic behavior. But one more time, it's not a schizophrenia. It's a schizophrenia-like signs, symptoms. Okay? All right? The most common hypothyroidism in United States is the Hashimoto disease. Thyroiditis, I'm not going to go into the classification. Thyroiditis, so when you have thyroid disease, thyroid gland disease, you can classify in hypo, in hyper, that is the Graves' disease, hyper, and the thyroiditis. This thyroiditis means inflammation of the thyroid gland. It can be caused by viruses, by bacteria. They can produce by autoimmune disorder. So this thyroiditis, at the very beginning of the process, is going to be hyper, because it's like you have a sponge inflammation. All the thyroid gland is releasing all the T3 and T4. It's inflamed, the thyroid gland. But after that, they deplete the thyroid gland. They turn now into hypo, and that is where they stay the longest time. In thyroiditis, the thyroiditis Hashimoto, there is a very early stages that you are hyper, but then most of the time you become hypothyroidism. Okay? Any question?
No.
Okay. All right, so blood test. So now, okay, so I'm going to. Oh, God, I cannot. All right, so now let's do a little bit of clinical. Very simple. Look at this. We have the pituitary gland. Again, yes, pituitary gland. And the pituitary gland is going to produce which substance, which hormone? Huh? Which hormone stimulate the thyroid gland coming from the pituitary gland? Please tell me.
TSH.
TSH. So please, everybody participate, please. That is motivate me. If you don't participate, looks like you are not interested. Please, okay? Just make some sounds. Tell me that you are there, please. All right. So otherwise, I'm just going to just do what? I mean, the class is not just me. The class is everybody. All right. So we have TSH. If the TSH is low, is the thyroid gland produced, we have hypothyroidism, and on the other side, we have hyperthyroidism. We are talking about the lab test now. So in hypothyroidism, we have low, I'm going to put here, low T3, low T4. In hyperthyroidism, you're going to find high T3 and high T4. So if you have a serum test, blood test, you're going to find, in this case, hypothyroidism is actually low T3 and T4, and hyperthyroidism is going to be high T3 and T4. Now, look at this. If you have low T3 and T4, what happened? The pituitary are going to put TSH here. The TSH are going to, first of all, the hypothalamus is going to know that you don't have enough T3 and T4. So hypothalamus is telling the pituitary gland to produce more TSH in order to compensate and increase the T3 and T4. But the patient cannot produce T3 and T4 because they don't have iodine, for example. So what happened? The TSH is going to be very high, because the body is desperate trying to tell the thyroid gland to produce more T3 and T4. So what is the laboratory test here? The laboratory test in blood will be low T3, low T4, and high TSH, hypothyroidism. And in this case, you have high levels of T3 and T4. High levels of T3 and T4. Who produce that? The thyroid gland. There's some nodules that are going to explain another time. So these T3 and T4 are produced by the thyroid gland. So you have too much T3 and T4. So this is too much T3 and T4. Who knows this? The hypothalamus. The hypothalamus is going to say, oh, okay, so we have too much T3 and T4. Okay, I'm not going to say anything to the pituitary gland. And the pituitary gland, what it's doing is to lower the secretion of TSH, because you don't need it. You have already a lot of T3 and T4. So the laboratory test for this is going to be high T3, high T4, and low TSH. That is the hyperthyroidism. You okay with that?
Yeah.
Okay, thank you. All right, so that is the cartoon that you can do at home. Let's keep moving. All right, look at this. This is a posterior view of the posterior. Huh? You're looking the thyroid gland from behind. You have 1, 2, 3, and 4. You can have 4, 6, 8 even. So those are the parathyroid gland. So they measure about 2 millimeters. The thyroid gland is going to measure about 5 to 6, 4 to 5, and 2 to 3 depth. So that is about. All right, so we already talked about that. The tetany, please, tetany and flaccid muscle, right? Tetany, low calcium. When you have hypocalcemia, tetany. When you have hypercalcemia, you have flaccid paralysis, flaccid muscles, flaccid muscles. All right, so let's talk about the adrenal gland, and that is huge. Okay, so here is where we are going to have, and diabetes mellitus is another big topic. All right, so let's talk about the adrenal gland. Okay, so adrenal gland is part of the HPA. What is HPA, by the way? I said HPA several times. What is HPA?
Hypothalamic axis.
Hypothalamic pituitary axis. Excellent, right? And the ACTH is going to produce this, is going to follow this axis. So we have the hypothalamic pituitary adrenal gland axis that is part of the HPA. All right. So now talking about the adrenal gland are going to be two adrenal glands. One on the, they are located where? On the top of the kidneys. On the top of the kidneys. On the top of the kidneys. On the top of the kidneys are going to be one adrenal gland, each kidney. So they are going to be, just to give you an idea, my head is the kidney, and I have a hat like this on the side, like this on the side. That is basically the position of the adrenal gland, just to make it simple. Now, adrenal gland, let's cut it in half. Let's cut it like a fruit, and you're going to have this configuration. So, as you know, this portion, the outer portion is called the cortex. Is the cortex. And the inner portion is called the medulla. Is the medulla. Just to finish with this, just what is doing the medulla? Because I want to focus, but I want to review a little bit here about for the midterm. So here we have the spinal cord. This is the spinal cord, and the spinal cord are going to have, you know, here this area is parasympathetic. This area is parasympathetic. The cranial and sacral are parasympathetic. Parasympathetic, cranial are going to be, for example, the cranial nerves. And here we have the sympathetic. This is the sympathetic. All these lines that are coming here in the middle, in between the extremes of the spinal cord, are going to be sympathetic. Some of these fibers are going to get into the adrenal gland medulla. So these are going to stimulate the production of adrenaline or epinephrine or noradrenaline or norepinephrine, right? So that is the sympathetic nervous system. This, listen, there is a question about this. Do not follow the HPA. Do not follow the HPA. The medulla do not follow HPA. Do not follow HPA. Do not follow the hypothalamic pituitary adrenal gland axis. There is no axis with the sympathetic. Is that clear?
Yeah.
Yes.
Now, in addition to that, just remember the adrenaline or epinephrine and the adrenaline or norepinephrine all are together, all are called catecholamines. Catecholamines. Catecholamines that they have an adrenergic effect, looking for adrenergic receptors, alphas and betas. Okay, so let's go back to our adrenal gland cortex. So we have here we are going to have the axis, the HPA. HPA, we have the hypothalamus, and the hypothalamus is going to go to the anterior pituitary gland, and the pituitary gland, what is doing is to secrete the ACTH. The adreno means adrenal gland, cortex. All this is the cortex. Tropin action hormone. So here we have different layers of cells. Actually, what I want you to remember is the GFR. No, GFR is going to be another mnemonic because it's the G means glomerular, F fasciculata, and R reticular. So areas of the adrenal gland cortex. I don't want you to remember that. I'm going to go straight to the point. These adrenal gland cortex are going to produce, one is the aldosterone. Second, are going to make it like this, okay? Like a layer like this. Just to see that each layer have a function. The second layer are going to be, or below this is going to be the cortisol. The cortisol is going to be produced in this area, all this area. And the most inner portion are going to be the sex hormones. All these are immersed in the cortex of the adrenal gland. So this ACTH, what it's doing is go to the adrenal gland and is going to produce aldosterone, cortisol, and sex hormones. The most important of these secretions at this time is going to be the cortisol. Okay, the aldosterone. What is doing the aldosterone? Listen to this, please. Aldosterone, please, aldosterone reabsorbs sodium. That's what I want you to remember. Yes, but there is something else. Reabsorption of sodium. When sodium is reabsorbed, never forget that sodium is being followed by water. Water loves sodium. Wherever sodium is going, the water is going to follow the sodium. So the sodium is getting into your body and is going to pull water into your body. So that means there is more volume of blood in your body. More volume of blood can increase the blood pressure. Okay, because the heart needs to move more volume of blood than before. Aldosterone. This aldosterone, because, and that is what I want you to remember, is, this is already known, sodium is a mineral. So aldosterone is called a mineralocorticoid. Why? Because mineral, who is the mineral? Sodium. So that's why aldosterone is going to call mineralocorticoid, because of the sodium. Is that clear?
Yes.
Okay. All right. So now, the next one is the cortisol. The cortisol are going to be table of 10. Remember the table of 10? Table of 10. Number one, what is the function of the cortisol? It's called the stress hormone. Yes, when you are stressed, you're going to produce more cortisol. Okay? Number two, make you awake. The cortisol are going to be produced like this: AM, PM, AM, PM. The cortisol in the morning is high. At night is going to be low. In the morning is going to be high. And at night is going to be low. So high cortisol here in the morning and low at night. Why? Because before that, just follow this. I'm going to complete with this. Number three is going to increase the glucose in blood. What you need to remember for the exam is that if this process is called the gluconeogenesis. is the gluconeogenesis. The gluconeogenesis, that is the word. Increase glucose in blood. Okay, so now listen to this. You are actually open your eyes in the morning, and you, as the first millisecond you open your eyes, you are stressed already. Yes, you are stressed. That is normal. That is needed. We want to have that stress in the morning because cortisol are going to increase the glucose in blood. At that moment, you was sleeping 4, 5, 6 hours without eating. So you have low levels of glucose in blood. So in order to start your day and start to have this activity, you need to have some energy. You didn't eat yet. So that's why you are going to increase the cortisol. Cortisol, what it's doing is going to make you awake, and that moment you start to have production of more sugar in your blood, right? And that is going to help you to start doing your day. You okay with that? Now, when you are overstressed, you cannot sleep at night. When you're overstressed, why? Because the cortisol is making you awake. So that's why when you're stressed out, you cannot sleep, because the cortisol is what it's doing is to make you awake. You okay with that?
Yes.
Number 4, huge, is going to depress the immune system. Depress the immune system. So the aggregation of the prostaglandins, the leukotrienes that are going to call the white cells, are going to be diminished. So what does it mean? That the white cells are not responding. So you have a depression of the immune system. Your immune system is actually weak, become like they're like drunk. They don't know what to do, where to go. So depress the immune system. A proof of that. Tell me, do you know somebody who is stressed out all the time? And do you notice these patients or these persons who are stressed all the time, for whatever reason or no reasons, they are stressed out all the time, they are getting sick more often than others? Do you notice that or no?
Yeah.
Yes.
Right. Why get sick with viral infection or cold or flu or whatever other viral infection, bacterial infection? Why? Because they are so much stressed out that they produce so much cortisol, and the cortisol, what is going to do is to depress the immune system. So you are more easier to get infections. You're not as protected as before. You okay with that?
Yeah.
Number 5 are going to produce osteoporosis. Osteoporosis. What is osteoporosis? It's the diminish of bone deposit or calcium deposit in the bones. So there is many medications that are going to be using cortisol. I'm going to take my time to talk about that. So this cortisol, when you don't give it to kids, children who are still growing, don't give cortisol unless it's needed. Is very needed, right? Why? Because if the patient with cortisol, with a kid, giving a regimen of corticoids all the time, actually they are going to basically close the epiphyseal plate, the growth cartilage, very soon, and they are not going to grow as much as should be. Osteoporosis in adult, that can produce weakening of the bones too. People who are having autoimmune disorders, and you already know what is an autoimmune disorder, is when your immune system attacks your own cells, your own body, right? With inflammation, with inflammatory process. Okay. Osteoporosis means low density low bone density. Number 6. Who can help me? Is going to be anti-inflammatory. Anti-inflammatory. Yes. Tell me, when you have a carpal tunnel syndrome. So you know somebody with carpal tunnel syndrome? Yes or no?
No.
Yes.
No? Okay. And tell me, what was the treatment for that? An injection of cortisol or cortisone?
Yes.
Yeah.
Right? And what happened with the pain? The pain is gone, correct?
Hmm.
Right? Right. Okay.
Yeah.
So, but the corticoid is not used for pain. Mainly that very much in our minds. Cortisol do not produce decrease the pain. What is doing the cortisol is to decrease the inflammation. And you know that inflammation, the 5 cardinal signs of inflammation is going to be pain, is going to be heat, is going to be heat, pain, redness, right? What else?
Swelling.
Swelling, edema,
Lose
edema,
Loss of
function.
function.
huh?
Lose
Edema and
function.
loss of function. Okay. So this edema, swelling, is what is accumulation of fluid that compress the nerves. And that is what is causing the pain. But when you are treating pain, like for example, aspirin, all that, they are going to go directly to uh, to the to the cells who or the substance who produce pain and the receptors. But this is not. What is doing is the corticoid, what is doing is to get rid of the edema, of the swelling, that produce that mechanical compression of the nerves. And that is going to be resolved. And the pain is going to go away. But it's not a painkiller, the cortisol. Cortisone is not a painkiller. You another example: go to Safeway, go to Walgreens, and buy this cortisone. It's for skin. Remember, cream. Do you see this? When you have some minor inflammations on the skin, you can apply that cream. But it's not for pain. It's just for inflammation. Is that clear?
Yes.
Number 7, water retention. Water retention. Water retention. You get swollen. Okay? Water retention. Why? Because water retention, because the cortisol is very close, is a cousin of the aldosterone. They have a little bit of aldosterone function. So that's why water retention means sodium retention. So that's why you can get swollen too. Number 8, you have irritability. Irritability. The irritability means that you become very apprehensive. So you're very irritable. So your mood is very, very much changing. Okay? Your mood, you're very moody. So irritability. Number 9, increase gastric acid. Increase gastric acid. So if you have this cortisol, and that is not a minor sin, huh? Because you're going to see that very soon. So you need to know all the table of 10. All right? So increase gastric acidity. You can have gastritis. And number 10, that I have it in my head, now it's gone, is the lipolysis. Lipolysis means that you produce more, you take the triglycerides and break it down, and you have more fatty acids in your blood. So those are the table of 10 of the cortisol, the table of 10 of cortisol. Okay? So now just remember this rhythm we have here, this rhythm is the circadian rhythm. Circadian rhythm. Circadian rhythm is the circadian rhythm. Circadian rhythm means that you have high in the morning, so it's a cycle during the day. High in the morning, low at night. High in the morning, low at night. You okay with that? Now, the other name of cortisol. The cortisol are going to be called the glucocorticoid. 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 Question for the exam. That is money in your pocket, right? glucocorticoid. Why is called glucocorticoid a cortisol? Because increase the glucose in blood. It's very, very common. Okay? One example that you need to, for medication is going to be the prednisone. The prednisone. Okay? All right. So that is one example of these glucocorticoids. All right. So now we have the sex hormones. The sex hormones are going to be the estrogens, the progesterone, and the testosterone. There is a lot to talk about that, but it's not the scope. So sex hormones are going to be the estrogen, progesterone, and the testosterone. So how to remember all these cortex? Look at this. Aldosterone, sodium, right? Yes or no?
Yes.
Salt. Cortisol, glucose, right? Increase glucose or no? Cortisol.
Yes.
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 Yes. Sugar. And these hormones are what? The sex hormones. So that is what we call the triple S. The salt, the sugar, and sex. Salt, sugar, and sex. We okay with that?
Yeah.
Okay, so somebody's trying to kill us. So, okay. I don't remember who was that. Okay. All right. Aldosterone, cortisol, and sex hormones, all these are coming from cholesterol. So all these aldosterone, cortisol, and sex hormones are going to be called steroids. That's why they're called steroids. Steroids. So aldosterone is a steroid. Cortisol is a steroid. Progesterone, testosterone, and estrogens are steroids. The aldosterone is an steroid that is called the mineralocorticoid. The glucose is called is a steroid that is called the glucocorticoid too as well. You okay with that?
Yes.
Okay. Now let's keep going this. Look at this. When you have this, I'm going to erase this because you already have the idea about that. So here we have the cortisol, the aldosterone. Oh God, okay. The aldosterone and the sex hormones in this cortex. Now, what about here we have aldosterone and in this portion aldosterone. In the second we have cortisol. In the third we have sex hormones. Okay, so now look at this. What happens if I have a tumor? If I have a tumor here in this area of the cortex, what is going to do? It's going to produce high levels of aldosterone. And if you have high levels of aldosterone, you need to know the function. The function is to reabsorb sodium. When they reabsorb too much sodium, they are going to bring a lot of water into the bloodstream. So the heart needs to pump more volume of blood because you have too much aldosterone. Aldosterone are going to reabsorb sodium to where? To the blood. That is where the sodium goes. And when the sodium goes to the blood, the water is going to follow the sodium and they go into the blood. So you have much more volume of blood in your body. So the heart, when you have much more volume, they need to pump much more, harder, because it's more volume of blood that they need to move. And that can lead into hypertension. So high levels of aldosterone. So that is called, I don't want you to remember, is the primary hyperaldosteronism or COM disease. So I just want to do the easy way. Increase aldosterone, what can cause is hypertension. Cortisol. Cortisol, when you have a tumor here in the cortisol, in the area, they produce a lot of cortisol. And one of the problems that you have on cortisol is what we call the Cushing syndrome. Cushing syndrome. Cushing syndrome, and we have Cushing disease. Cushing disease is when you have a tumor. That is going to give you this appearance. That is Cushing syndrome. We are going to see that. Cushing syndrome. So the patient was very thin and now become very, very, very big. So they have what we call a buffalo face. No, buffalo face. No. Moon face. Sorry for that. Moon face. Moon face. And on the neck, this is the neck of the patient. This is the head of the patient. On the head, on the neck, they have a bulging area. That is called a buffalo hump. Buffalo hump. So this is the nose, this is the eye, the ear, the hair, whatever. And on the neck, they have this actually like a hump. That is Cushing syndrome. Now, what is the difference between Cushing syndrome and Cushing disease? Cushing disease is when you have a tumor in the adrenal gland cortex that produce a lot of cortisol that can lead into Cushing disease. Cushing syndrome is when you administer too much corticoids in the patient. Who receive too much corticoids? Patients who, for example, have rheumatoid arthritis. One of the main treatments is corticoids or glucocorticoids, as we want to call, right? Then you have lupus and others, psoriasis, myasthenia gravis, multiple sclerosis, Crohn's disease, chronic ulcerative colitis, so many others. All right, so that is the difference between syndrome and disease. Syndrome is when you have too much medication, too much drug, too much corticoids. And disease is when you have a tumor there. You okay with that?
Yes.
Yes.
Now, in sex hormones, we have estrogens, progesterone, and testosterone. What about if you have a tumor here on the area where produce a lot of estrogens? If you are a boy or a man, you're going to have the feminization. Feminization. So, characteristics. So, your voice start to be more soft. The distribution of hair is going to be different. The distribution of the fat are going to be different. That is going to be the feminization, right? Now, if that happens in girls, well, it's okay. More estrogens is going to have all these characteristics of a female, distribution of fat, etc., right? But here now, if you have testosterone, if the tumor is going to be in the area that produces testosterone, and that is on a girl. So what happened with the testosterone in the girl? So that is going to produce what we call the virilization. Virilization. I'm going to write it down better here. My God, what happened with my eraser, please? The virilization. Virilization. And one of the characteristics I want you to remember is the hirsutism. What is hirsutism? Hirsutism means hair on your face. But this is not like a small, very light hair. It's going to be like a beard. Like a beard. So basically, it's like a man, when they shave, they have that thickening of the hair on the face. That is actually hirsutism. That is what we call the virilization, and the characteristic is hair on the face, like a beard, very thick hair. You okay with that?
Yeah.
Okay. All right. So that is what we was talking about. All right. All right.
So
All right. Oh,
that's the woman getting testosterone hormones. So she
yes.
has hair on her face.
Yes. It's called
Okay.
hirsutism. Hirsutism. Okay. We have the Addison disease. Addison disease is basically when you have an hypofunction of the adrenal cortex. All right. So Addison disease, write down this, make your skin tan. Your skin become darker. Your skin become very dark. When you can tell this is deficiency of the adrenal cortex. So first of all, let's start with the beginning. Who or what can produce Addison disease? Is the hypofunction of the whole adrenal cortex, and that one of the commons is the tuberculosis. Tuberculosis. Tuberculosis is not only for lungs. Tuberculosis can happen in your skin, in your bones, can happen in your lungs, can happen in your liver, can happen in your kidney, can happen in your brain, can happen in your skin. Tuberculosis can happen any place. Now, this tuberculosis affect to the adrenal gland. When that is the case, it's going to destroy the adrenal gland. And that's when you get into hypofunction of the adrenal cortex. There's one of the causes, okay? That is called Addison disease. And the darkening of the skin is the characteristic of this Addison disease. So how you can tell? Look at the hands. The creases, the lines that you have in your hands are more darker than the rest of your palm, right? Generally. But these lines become very dark, very, very dark, very notorious, very evident that is a very, very like almost black color on these lines. That is plus the color of your skin are changing. There is more, but I'm not going to go on that. Okay, so there you are. There is Addison disease. This is a white person. Actually, that's like a bronze bronzed skin. All right. Okay, we okay with that. Addison disease, obviously, that is two different persons. So you have here the creases are going to be very remarkably darker than the rest of the hand. Very, very much darker. All right, so that is another. So you have, just to show, when you put up here the lips, you will see all the gums are black, completely black. That is another Addison. So what you need to know is Addison disease is actually insufficiency of the adrenal gland cortex. Any question?
No.
Okay. Now, what I'm going to do is this. Let's have a 1:35 break, okay? Because what is coming is the cookie, is the best of the lecture. All right, so go have you do exercises, push-ups, whatever, take your glucose, and then come back. So I will see you 11:35. Okay, everybody is ready? Okay, I think we... All right, so let's get started. There's other pathologies that I wish I could go here, but definitely I think it's enough for that. All right, so let's talk about the pancreas. Please, the pancreas, okay, pancreas is a mix gland. Pancreas is going to be a mixed gland. What does it mean? They have endocrine function and they have exocrine function. Just to refresh you, exocrine function, exocrine gland is the one who have a duct. And the endocrine, ductless, like the thyroid gland, for example, is a ductless. Okay. All right. So the ductless. So endocrine function of the pancreas is going to produce three hormones. One is the insulin. The other one is the glucagon. And the other one is the somatostatin. So those are the three hormones. There's another BIP. I'm not going to talk about that. But insulin, glucagon, and somatostatin. And we are going to need to know the functions of them. The exocrine are going to be the pancreatic juice. That you already know what is a pancreatic juice. I'm going to refresh. Pancreatic juice is the lipase composed by the protease, composed by the amylase, composed by water, electrolytes, and I put at the end the very important one, the bicarbonate. It's called bicarbonate. Okay, perfect. All right, so this gland we are going to be located posterior to the stomach, behind the stomach. Okay, and actually it's going to be in basically in the epigastrium going to the hypochondriac area. All right, saying that, this is just to show you, first of all, we have the insulin glucagon, just to show you here, this is the duodenum, this is the duodenum, all this is the duodenum, here's the duodenum, and here we have the bile duct, here we have the pancreatic duct where is coming the pancreatic juice, they go into the duodenum. If you remember, this is going to have the Oddi sphincter, this is a review, and they are going to drain into the duodenum. Here is where we have the most numerous chemical reactions for digestion. All right, so that is the exocrine gland portion of the pancreas. So here we have the pancreas. Yes, here again is the duodenum. This is the duodenum. This is the pancreatic duct, or called the Wilson duct, Wilson's duct, or pancreatic duct, are going to collect all the pancreatic juice. Now, here in this pancreas, we are going out of the exocrine, we are going to talk about the endocrine, that is the topic today. They have like a small islets distributed basically mostly on the tail of the pancreas, or at the end of the pancreas. There is some here, but most of them are going to be located here in this area, on the distal portion of the pancreas. These are called the islet of Langerhans. The islet of Langerhans. Islet of Langerhans. Okay. So here we have one of these. Just remember, we have grapes in the gelatin. The gelatin is the pancreas, and the grapes floating in the gelatin, already hard, are going to be the islet of Langerhans. These are going to put here one of the islets of Langerhans. This is one islet of Langerhans. This is one Langerhans islet. Okay? And here we are going to have different cells. Here we have one type of cell that is called the alpha cell. Another blue, where is the here? Where is the blue? Okay, beta cells here. Beta cells, that is basically the blue, just make a mistake here, blue. And we have the delta cell. We have alpha, beta, and delta cell. Of course, it's not nothing to do with the alpha receptor, beta receptor. It's totally different. It's called alpha and beta cells. Those are cells, those are receptors. These alpha cells, alpha, are going to produce the glucagon. And the beta are going to produce the insulin. And the delta cells, this is the symbol for delta in Greek alphabet. Delta is the same to say this. Delta is going to produce the somatostatin. Somatostatin. Okay? So the majority of cells are going to be beta cells, the ones who produce insulin. All right. So let's get into the topic. The insulin, what it's doing is this. This is the insulin. This is the cell. This is a cell of the body. Could be in your liver, could be any part, any cell. And what is the insulin is coming from the pancreas, right? The insulin is produced by the pancreas, the endocrine portion. And what is doing the insulin? The insulin is going to actually look for receptors. Let's make the insulin in this shape. So the insulin is coming here and is going to activate the receptor for insulin. And what happened? They're going to open a door for what? For the glucose. So the glucose get inside the cell. The glucose get inside the cell. The glucose inside the cell. Please make me a favor. I want you to remember that when the glucose get into the cell, they enter with a little bit of potassium. That is an extra. So please, they enter with, that is going to be useful later on. But you need to know this right now. So glucose enter. So it's like you have a male person, a male man, or okay, knocking the door, and they put the package in your hands. Open the door and you put the package in your hand. They put the package in your hand. So the mailman is going to be the insulin. The receptor are going to be the ring bell. And you open the door and the package is the glucose. The glucose is given to you, you close the door. So the mailman is not going to get into your house, right? So he's going to continue his delivery, right? So that is what is doing the insulin. So insulin put glucose inside the cell, or make the enter glucose inside the cell. All right? So now we have the glucagon. The glucagon is doing the opposite. So if we have here, for example, glycogen, mostly, we have 2 pounds of glycogen, and this glycogen is going to be mostly on the muscles and the liver. So those are the 2 areas where the glycogen is. So, and the glycogen is actually composed by hundreds of number of glucose molecules. So we have glucose, all glucose together are going to form what we call glycogen. Okay, glycogen. So these glycogen are going to turn into glucose. So the opposite. So glycogen is a group of glucose. Now we are going to break down the glycogen, and the glycogen is going to release a lot of glucose. And these glucose are going to come out from the cell, out, the glucose. So who is doing that? Is the glucagon. Is that glucagon. So glucagon, what it's doing is the opposite of the insulin. You okay with that?
Yeah.
Okay?
Yes.
All right. All right, so what is doing the somatostatin? Remember the insulin is the beta cells, the glucagon are the alpha cells, and the somatostatin is coming from the pancreas. Somatostatin are going to basically regulate the insulin and the glucose. It's like the referee. It's like actually like a dealing too much insulin or too much glucagon, so they are going to regulate, not to have too much or too little insulin, or not too much or too little of glucagon. So that is the somatostatin. Okay? All right. So let's go into diabetes mellitus. And with that, hopefully we finish. All right, so talking about diabetes mellitus. Let me explain this to me right now. God, okay. Diabetes mellitus is a very important. So we have many cases. So we will talk about another time. It's not that time. Diabetes mellitus. Diabetes mellitus. Diabetes means in Greek faucet, running water. Running water. And mellitus is called sweet. Sweet. All right. So basically, P is releasing urine. Urine is releasing glucose. All right. So P with glucose. That is what is diabetes mellitus. In the past, they was calling the melting flesh. The melting flesh. That is, in the past, melting flesh, they were thinking that the body was basically dissolving from inside, and they was getting out all the muscles, internal organs, was like a melting and getting into the urine. So that is what is called the melting flesh. Okay. Now, saying that, we have two types of diabetes mellitus. We have three types, four types. Okay, let's start. Diabetes mellitus. We have diabetes mellitus type 1. That is the insulin dependent. So that means that the patient do not produce no production of insulin at all. There is no production of insulin at all. Diabetes mellitus type 2 is going to be insulin resistance. That means that they have insulin, but the insulin is not working. It's like you have the key, that is the insulin, and the keyhole is changed. So you cannot make the insulin work, open the door. So in both cases, because there is no insulin here in diabetes type 1, there is no insulin, the glucose cannot get into the cell. If the glucose cannot get into the cell because there is no insulin, that is going to lead into hyperglycemia. 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 Makes sense, right? Now, diabetes type 2 is insulin resistance. So there is insulin, yes, there is insulin, but the insulin cannot work. So it's the same situation. Insulin is not working, cannot make the glucose get into the cell. And what happened? They're going to lead into hyperglycemia. 10% of all the 32 million people that we have with diabetes in the United States are going to be diabetes type 1. And 90% of the cases are going to be diabetes type 2. Okay? You okay with that?
Yes.
Yes.
Hyperglycemia, signs and symptoms are going to be these. P, polyuria. You pee a lot. Increase urine diuresis. So you pee a lot. Every 10 minutes, 15 minutes, you go to pee. Because of you're losing this water, you're going to have polydipsia. Polydipsia. And polydipsia means that you drink a lot of water. Why? Because you're losing a lot of water. Polyuria, polydipsia. Polydipsia means you drink a lot of water. Polyuria means you pee a lot. And the last one is the polyphagia. Polyphagia. Polyphagia, you eat a lot. Why you eat a lot? Because the glucose cannot get into the cells. So your body is starving, is actually hungry. So that's why the body thinks that you don't have glucose in your body, and you start to eat, and eat. But the glucose still cannot get into the cell. So you actually eating and eating. That is what we call the 3 Ps. Polyuria, polydipsia, and polyphagia. Okay?
Yes.
Okay. Now, the last part of this, what time is 8 minutes? Oh, okay. Is this. Now, let's make a summary of many things here. Number 1, glucose into the cell. All this is the cell. All this is the cell. This is the cell. The glucose enter into pyruvic acid. Then that is going to be reversible to ATPs, etc. And then they go into acetyl-CoA. The acetyl-CoA go into the Krebs cycle. And this is in the mitochondria to produce ATPs. Okay? Simple graphic. Now, what happened? If you have hyperglycemia, that means because the insulin is not working, okay? So there is no glucose here in order to provide the Krebs cycle. So glucose cannot be used because the glucose cannot get inside the cell. Cannot get inside the cell. When they cannot get inside the cells are still need to produce energy. They are going to shift from glucose because there is no glucose in the cell coming from the blood. There's no glucose at all because the insulin is not working or resistant to the insulin. What is going to take hand the cell are going to be the fatty acids. The fatty acids. The fatty acids are going to produce acetyl-CoA, right? So you cannot produce this because there is no glucose here. So the fatty acids are going to turn into acetyl-CoA. And acetyl-CoA are going to produce 180 ATPs. That looks okay, looks good, but it's not that paradise. Why? because when the fatty acids are going to turn, I'm not mentioning the beta oxidation, the fatty acids are going to get into acetyl-CoA, that they are going to produce another substance that is going to be called the ketone bodies. The ketone bodies. These ketone bodies are actually three. I'm not going to mention the names. Ketone bodies or ketones, called ketones or ketone bodies, the same. These are very acid. Very acid. These are very, very acid. This acidity are going to go into the bloodstream and produce metabolic acidosis. So that is the problem with patients with diabetes mellitus. If they cannot control, if they cannot control the glucose in blood, too much glucose in the blood means that the cells are not using the glucose. So the glucose are going to shift from glucose to fatty acids. And these fatty acids can lead into death of the patient. So fatty acids are turning into acetyl-CoA, can produce ATP, but at the same time produce the ketone bodies. And those ketone bodies or ketones are going to produce this metabolic acidosis. And that can kill the patient. You okay?
Yes.
All right, so that is a very fast review about what we are using in the past. All right, so what time is it, please?
156.
Okay, give me 10 more minutes, please. 4 minutes after 2. All right, so let's see. What else? Okay, so let's talk about diabetes insipidus. Let me see one more thing. Oh, yeah, another thing. When you don't, for example, you are fasting, you don't have glucose in your cells, or when you are diabetic patient, you don't have glucose inside the cells neither. Okay, what are the mechanisms, compensatory mechanisms that produce glucose? Number one is going to be the adrenaline. Adrenaline, when you are in fight or flight, they are going to release glucose into your blood. Why? Because you need more energy to escape, to run, etc., etc., etc. Right? Number two are going to be the glucagon. Glucagon, what it's doing is the glycogenolysis. Number three, you increase in the stress, you increase the cortisol. Cortisol is the stress hormone. And that is going to increase the glucose, the table of 10, through the gluconeogenesis. And another hormone that is increasing the sugar in blood is going to be the growth hormone. When you are using growth hormone, you need glucose. So basically activate all the glucagon or cortisol, but the growth hormone is going to participate in this. So when you are in fasting, you are not eating, you're hypoglycemic. When you are having diabetes, you have hyperglycemia, but you're still not using the glucose in your cells. That is going to be the 4 mechanisms that are going to participate in the elevation of glucose, because the body thinks that you are not eating. The body tries to get glucose from somewhere in order to basically use for ATPs. And those are the 4 mechanisms of compensatory that produce glucose in case that the cells do not have glucose. So they are trying to, adrenaline increase the glucose in blood through that glycogenolysis, similar. Glucagon, the same. Cortisol, gluconeogenesis, and the growth hormone that is going to use this process. What I want you to remember, adrenaline, glucagon, cortisol, and growth hormone elevate glucose in blood. So those are the two types of diabetes mellitus that we was talking. We have other that is, I'm going to mention, gestational diabetes. These diabetes are happening in females. Basically, after 20 weeks of gestation, they are going to have high levels of glucose. So babies the mother have a lot of sugar, glucose in the blood. This glucose go to the baby, and the baby is going to grow very big. So those are what we call big babies at the time of birth, or they born. So that's why it's gestational. Just to mention, the other type of diabetes is diabetes mellitus, diabetes insipidus. Insipidus means no taste. And what is diabetes insipidus? Diabetes insipidus is the excess of ADH. Increase of ADH. The diabetes insipidus is going to be an increase of ADH. What is doing the ADH? ADH is going to is the opposite. Is poor production of ADH. So low production of ADH. Sorry for that. ADH. Because the other one is the CHAT is another thing. ADH, low production of antidiuretic hormone. If you have low production of antidiuretic hormone, diuresis means to pee. Antidiuresis means to retain. If you have low ADH, you're going to pee a lot. So that's why it's similar to diabetes mellitus, but it's not diabetes mellitus. Because diabetes insipidus, the only signs and symptoms that we have is the polyuria and polydipsia. So why diabetes mellitus? What they have is polyuria, polydipsia, and polyphagia. But diabetes insipidus is going to be low levels of ADH. So you have actually a lot of pee, and when you lose a lot of pee, you have actually a lot of, you want to drink a lot of water. You okay with that?
Yes.
Okay. Let me see if I missed something here. Yep. All right, so the last gland I want just to go over. Let me see if I have something here. Yeah. The last gland is something that you already know. It's called the pineal gland. The pineal gland. You remember the pineal gland? The pineal gland is actually what we call the pineal gland is going to produce the hormone called the melatonin. Don't get confused with melanin. Okay, melatonin is the hormone produced the pineal gland. And the melatonin, what it's doing is to induce sleep. Okay, and what I want you to remember about the pineal gland is that is what we call the Dracula hormone. The Dracula hormone. What is the Dracula hormone? Dracula hormone. At what time came Dracula? Tell me. At what time is coming Dracula?
Night.
Night, right? So that is what the pineal gland produces the melatonin at night, not in the morning. All right. All right, so there's a few things here and there I want to talk, but I think we have a very productive day, as my point of view. I want your opinions, please. We finished the class, and Jasmine, please, your opinion or your comment. You pass, or you're okay, you're happy, you're unhappy, you're what? Tell me.
I'm okay. I need to definitely go over it again. This one.
Okay. Miss Lee? Miss Lee, can you hear me?
Yeah, I hear you.
Any comment about the lecture?
No, I think it's good.
Today what?
It's good.
Dr. G, I have a concern. Can you hear me?
Yes, I can hear you.
I want to know, so for the midterm, if you could just repeat it again, the information that we're going to be tested on, this is going to include this chapter 13 and 14.
Yes.
Is it going to be primarily 13 and 14, or I just want to know exactly what to study for within the chapter?
Okay, I'm going to explain again. So one thing, please don't go yet. I want to say something here. Number one, the sensory organs, I'm not going to ask in this exam because we didn't talk about that. Okay? So that is going to be taken on the final exam. But next class, I need to finish the sensory organs. But the sensory organs is not going to be in the midterm. Okay? Okay.
Thank you.
Number one. Number two, I'm going to postpone the cranial nerves. Cranial nerves is a lot. And I know by experience that students, they have hard time to remember the cranial nerves. And that is a process. So I'm going to leave that for the final exam. So there is no...
Are you talking about the 12 cranial nerves?
Yes.
Yeah, okay.
So the names and the functions of the cranial nerves are going to be tested in the final exam. Okay? Now, the exam is going to be comprehensive. Comprehensive. From lecture 1 to lecture 6. Okay? So don't think the exam is a monster. It's not. Okay? It's actually, just think about it. If I have to ask all the questions I want for this midterm, I will ask you 500 questions. But I cannot do that. Okay? So I need to give 50 questions. That is what is the midterm. And for that, you need to know the basic knowledge of all the topics. Okay? So you need to go and sweep out all the topics, definitions, and what is the most relevant, important, and things what I remark in class. Okay? One more thing. Supposedly that we shouldn't be doing tutoring. This tutoring is an extra. It's not, I'm not, I will tell you, I'm not gaining any financial help on that at all. It's just on my side. Why are you doing that? Because I want it. Second, because it's definitely going to help you for your exams. And the tutoring is going to be tonight, probably at 10:30, because at 10. At 10, yeah, because I need to prepare things. Okay, at 10.
Don't you? We have a test tomorrow as well with Mr. Vedad.
Oh.
The test with Mr. Vedad at 9 o'clock.
But the other class doesn't get off until that time. That's why. The night class.
Tonight. Tonight
we have a test in the morning with Mr. Vedad as well. Oh.
Tomorrow morning you have exam.
Yes.
Oh, okay.
If you can postpone it to Thursday, we could attend the class today and tomorrow as a review, but it's just too much to study for his own, what learning 2 chapters from him as well.
Who's talking?
Me.
No, I cannot see you.
I'm over here.
Oh, Joy. Yes. So what is your suggestion, Ms. Joy?
No, I was trying to say if Mr. Vedad can push his test to Thursday, that would be good because we could do a review today, the way you want to give your class at 10:30 or 11. Then we could do a review again, same tomorrow, 10 or 11. Then we take your test. Then Mr. Vedad can just teach tomorrow. Then we take his test on Thursday.
So
if he could do that.
the only option I have, Ms. Joy, is just to do the review on Tuesday, because I don't want to mess up your exam by tomorrow.
Okay.
Okay?
Yeah, no problem.
Okay, so I will do that. There is no review tonight because you have exam tomorrow.
Thank you.
Okay?
Yeah.
All right. Okay, Joy. But Joy, you was upset. You was not upset, right?
It was just, I'm sorry, it was just too much. I'm not upset. It was just too much. And it's like
Okay, Miss Joy.
to compress.
Miss Joe, yeah, I understand you. So yeah, I'm very sport, so don't worry. So that is okay. All right. So Andrea, what do you think? We okay with that, or how we?
Yeah, thank you, Joy, for bringing this up because it's kind of a lot of material to review. Yeah, and we have to focus for tomorrow, especially in fundamentals. Some people have low score, so we need to focus on the test for tomorrow.
Yeah, very good. Okay, thank you. Aurora, what do you think? We okay with that?
Yeah, I'm fine with it.
When's the midterm again? Is it
Wednesday.
Wednesday? Because we're not
Yeah,
going to change it. You don't want to review tonight? You want to review just Tuesday only?
No, just Tuesday.
Not Monday, Tuesday. Okay.
Yeah, I will try to make a long review on Tuesday.
Is Tuesday 10:30 as well?
Tomorrow you have class?
Just at 2 p.m.
No, you have fundamentals tomorrow, right?
Yeah, from 9 to
So
2.
they're going to finish at 10 p.m.
Yeah, they finish at 10, the PM class.
Yeah, unless you want to just to skip night group. No, you don't want that, right? No. Let's do it at 10:30 as usual. Okay, so you have time to come back and take your lunch or dinner, glucose, and then 10:30 I will see you tomorrow. Okay?
Do we still need a test, a rapid test for Wednesday for the midterm?
Good question.
Rapid test? What do you mean?
Oh, do we need a COVID test for the midterm?
That's what I'm going to. Just a moment. Let me see.
Is the midterm in person?
Yes.
Yes.
Oh, wow.
Christina, come on. This is the first thing I'm telling everybody.
Yeah, at 9:30.
Oh my gosh. Oh, I see.
Let me, everybody.
Thanks.
Okay, so let me see. Let me call Mr. Verdad.
There's no access to it.
Hey guys.
Yes.
Can I ask you all a favor?
Sure.
Yeah.
So tomorrow I'll be
No.
working again. And I really need this.
I'll take the notes
maybe
and
you
I'll
could-
send it to you.
Yeah, please. That would be
Yes.
a big favor. And I'll be
Yep.
forever grateful.
I don't mind giving you notes. I'll be off that day.
I'll send you my notes.
I need to be at that
Thank you,
review.
Desperately need it.
Oh, are you hungry?
Not really.
Not really. Huh? You're not?
Not really.
Know what you have to eat?
Okay, so actually, I want to tell you that we are going to coordinate. We are going to coordinate with Mr. Verdad, and proof of that is that I'm going to invite him right now, and we can talk. Okay?
Okay, thank
Please,
you.
just calm down. Okay, so don't make a. Okay, be nice. Okay.
Slow down the cortisol.
Oh, no recording. Okay, thank you, Andrea.
No, I say low down the level of cortisol.
Oh, okay. So I'm going to, because I didn't ask him that I'm going to